Good morning, everybody. Okay, good. Hi, my name is Salem Yunus. I'm the nuclear medicine physician and the CNM vice president. It's an early morning, so we're gonna try to start our first session. And our speaker today is Naz Mirzaei. She's a PhD and is a medical science liaison at Live Molecular Imaging, which has an exclusive worldwide license for research, clinical development, and commercialization of number of PET tracers spanning two different therapeutic areas, including neurology and cardiology. So prior to joining the Live Molecular Imaging in 2021, Dr. Mirzaei completed her postdoctoral training, characterization neuropathological changes in postpartum retains from patients with mild cognitive impairment and Alzheimer's disease at Cedars-Sinai in Los Angeles. For her doctoral dissertation, she focused on evaluating two PET tracers for neuroinflammation and on a novel therapeutic approach in Alzheimer's disease at the Imperial College London in England. Dr. Mirzaei's research and clinical interests revolve around high specific and sensitive biomarkers for early diagnosis of several neurodegenerative disorders, including Alzheimer's disease. Dr. Mirzaei, the stage is yours.
Again, thank you for the introduction. Good morning, everyone. Thank you for joining us, and to those in person and those who are joining us on the virtual platform. Thank you to the organizers for the invitation. It's my pleasure to be here to review some data on the utility of amyloid PET tracers in Alzheimer's disease, as well as to give you an overview of Life Molecular Imaging's amyloid PET tracer, Neuraceq, also known as, fluorine-18, fluorobetaben. So these are my disclaimers. I won't go through each one, but I want to point out that the prescribing information for Neuraceq approved by Health Canada in 2017 is not different from that approved by the FDA in the US. So here's a slide to show Life Molecular Imaging's products and pipelines in development to address unmet needs in a couple of major disease areas, one being dementia and neurodegeneration, and the other being in the cardiovascular space. In the interest of time, I will not give an overview of each one, but I highly recommend that you look them up if you work in either of these fields. Neuraceq is our marketed tracer for amyloid plaques in Alzheimer's disease. We also have a couple of other tracers in advanced stages of clinical development, those being PI-2620 and also fluorobetaben, which is similar to Neuraceq, being used for cardiac amyloidosis in the cardiovascular space. Our PI-2620 tau tracer is being prepared for the phase 3 clinical trial as well. For today's talk, I will focus on Neuraceq. So here's an overview of the presentation in terms of optimization of AD diagnostics with brain PET. I will cover that, and then the value of knowing why early accurate diagnosis of AD is important, as well as the current and emerging tools to enhance the certainty of the Alzheimer's disease diagnosis, and what tools and PET imaging options are available, including amyloid PET, and then an overview of Neuraceq, its characteristics, how to scan and interpret the scans. So you all know that Alzheimer's disease is a common neurodegenerative disorder affecting millions of people worldwide. Currently, about 6.5 million Americans over 65 are living with AD. This number is on the rise, and by 2050, it's projected to reach 12.7 million, basically doubling compared to the current number of patients in the same age group. In Canada, there are over 700,000 people living with dementia, the main cause of which is Alzheimer's disease. And by 2030, this number is projected to go over 1 million. And by 2050, estimates show that over 1.7 million Canadians will be living with dementia. In terms of the annual incidence rate, there are 124,000 new cases of dementia diagnosed in 2020 alone in Canada. And that's, one every 15 hours. And by 2030, that will turn into 21 new cases every hour. AD is the 6th leading cause of death in the US, killing more than breast and prostate cancer together combined. And 1 in 3 seniors dies with Alzheimer's disease pathology or other causes of dementia. Over 11 million Americans provide unpaid care for these patients. So not surprisingly, AD is a staggering economical burden, costing the US alone $321 billion, and this is projected to reach $1 trillion by 2050. So clinically, Alzheimer's disease, or I might refer to it as AD, is a spectrum spanning a long asymptomatic period where pathology is present and accumulating in the brain before the onset of cognitive impairment and cognitive symptoms. And in this preclinical stage, there's hardly any cognitive decline or impairment. Then this leads to the MCI stage, so mild cognitive impairment, where you can start to see that development of cognitive dysfunction. And this is a progressive phase leading to full-on dementia and eventually death. And I just want to point out that this declining trajectory is different to that seen in normal aging. So in the preclinical stage, there's evidence of brain pathology accumulating for as long as 15 to 20 years, and some even suggest 30 years before the onset of clinical symptoms. And some of, towards the latter stages of preclinical AD, there can be subtle signs of cognitive decline, such as in episodic memory, but generally you don't see any clinical symptoms. So in the MCI stage, mild cognitive impairment stage, patients show accelerated decline with more prominent signs of cognitive decline, and they start to have more functional struggles with daily life and changes in behavior, with a high percentage of these individuals converting to AD within 8 years. In the AD dementia stage, patients have severe dementia, episodic memory loss, executive function impairment, loss of independence with, carrying out daily tasks. They suffer from behavioral and mood changes, and from, a pathobiological perspective, they can have extensive neuropathological hallmarks and, including cortical atrophy. So historically, AD was almost always identified using, using tools that were based on symptomatology. And, a patient would refer to their primary care physician, and maybe eventually, they saw a neurologist or a dementia expert, and then they would undergo these clinical exams and neurocognitive tests. Such as, the MMSC, CDR, and these are just, different names for different neurocognitive tests that are routinely done in the clinic. Relying on these clinical tests and exams alone can lead to 3 major, problems, and these are underdiagnosis, late diagnosis, and misdiagnosis. So underdiagnosis, studies have been done that have shown up to 50% of cases can be missed when relying on these cognitive and clinical assessments alone, especially in the early stages of disease. With late diagnosis, even after symptom onset, the diagnosis is often delayed by 2 to 3 years, and then they can also be misdiagnosis. So in the dementia stage, there's about 25 to 30% misdiagnosis and over 50% in the earlier stages, such as the MCI stage. And there are currently, no tools for preclinical stage diagnosis. So that was in the primary care setting. What about, dementia experts and specialists, and when they use these cognitive assessment tools, even then there's only a 65% accuracy in the diagnosis. So why does diagnosis matter? It matters because it can validate symptoms and concerns, identify and address treatable conditions, provide education and support services for patients, plan for the future. It can help them plan for the future, both in the, for the clinicians and the patients. It can prevent crises and secondary harms, and provide access to medical treatments and unlock clinical trial opportunities for patients that are suitable for these. So given that there are these limitations, technological advances can now provide the opportunity to balance this art of traditional clinical diagnosis with the use of biomarkers to enhance early diagnostic accuracy. And what are these recent developments in biomarkers based on? They're based on the pathological hallmarks of AD, first observed over 100 years ago by Dr. Alzheimer. And they include amyloid-beta plaques, which accumulate in the extracellular space. And they are made up of, sticky fibrillar sheets of amyloid-beta peptides. And the other hallmark pathology is neurofibrillary tau tangles, NFTs. And these are sort of composed of hyperphosphorylated tau proteins. They both can be disruptive to normal neuronal function and cognitive function later on, and they're believed to bring about neurodegeneration and brain atrophy that's often seen in Alzheimer's patients. So given that, before in the past, patients were often, clinically diagnosed and given a diagnosis of probable or possible AD, and definitive diagnosis could only be achieved at autopsy. Now using specific biomarkers, we can actually visualize pathology early in the disease course in living patients. So apart from, Neuraceq plaques, tangles in the brain, you also later in the disease course have generalized atrophy and neurodegeneration and enlargement of ventricles that's often seen on MRI scans. So using biomarkers to define the earliest stages of disease, the AD spectrum has been characterized into stages, with amyloid plaque accumulation remaining the earliest detectable pathophysiological change, increasing considerably in the sort of preclinical stage and plateauing by the time cognitive impairment is reported. This is then followed by, increases in other biomarkers thereafter. And that's why, amyloid accumulation being one of the earliest events in AD progression, that's why it has been the target of intense efforts to develop more and more sensitive and specific biomarkers, as well as being the target of therapeutic efforts. So currently the MCI, so the mild cognitive impairment and mild dementia stages, are identified as suitable time points in disease course for therapeutic intervention. And detecting AD during this early phase, provides the clinicians an opportunity to intervene before greater neuronal damage is done and more cognitive function is lost, which makes the need for early biomarkers, biomarker development and usage a necessity. So what are some of the treatments available out there currently, and traditional therapeutic efforts in AD in terms of prescription drugs have circled mostly around symptom management and relief, and numerous clinical trials have been conducted, and only a handful of drug options are available. The candidates in the clinical trials either did not work and the trials did not meet their objectives, or that the trials were terminated due to severe side effects. These drugs, are mostly used in people with dementia and not at the earlier stages of disease in the AD spectrum. So some of these, include cholinesterase inhibitors and NMDA receptor antagonists, and they, again, target the symptoms of the disease and not the underlying pathologies. So emerging therapies, on the other hand, are aimed at earlier disease stages with some new disease-modifying drugs, DMD, such as the monoclonal anti-amyloid therapies designed to target and remove this pathology from the brain. And in order to accurately identify the population that would most benefit from these therapies, we need to have that early and accurate detection of hallmark pathologies. One of these drugs, you may be aware, is Aduhelm or Aducanumab, which was the first drug in its class to receive accelerated approval by the FDA. It's indicated for use in patients with mild cognitive impairment, MCI, or mild dementia, so relatively early on in the disease course. And for full approval, further clinical trials are being run to show clinical efficacy. So in terms of, it's the impact of the drug on cognitive function, whether it's slowing down cognitive decline or halting progression. And there are other monoclonal antibodies that are being developed, such as lecanemab from Eisai in collaboration with Biogen, and they've shown a reduction in the rate of cognitive decline in patients that received the drug versus placebo. And a lot more results will be coming out from these clinical trials at the Clinical Trial in AD conference in November in San Francisco. So one thing I would like you to take away is that because amyloid is one of the key hallmarks and these drugs are targeting amyloid in the brain, we need to have specific markers that can allow subject selection for treatment or the clinical trials that are being done. For instance, here, this is one of the, the image on the right is one of the images that were shown in one of the early publications when it comes to Aduhelm, and they used amyloid-beta PET, and they looked at the baseline brain amyloid status, and you can see quite, extensive amyloid tracer uptake in the brain on the left-hand side at baseline, and then 1 year later, the placebo brain has not changed, whereas there's a huge reduction in the uptake of the amyloid tracer in the brain of people that received the treatment. And you can see this reduction has, works in a sort of dose dependent manner as well. And there are, potential new treatments being developed for AD. There are about 27 new treatments in phase 3 development. Some of them are, targeting the symptoms, and then the majority are actually disease-modifying therapies. So here's an overview of what's currently available to physicians to diagnose AD or dementia due to AD. In addition to the traditional tests, sort of looking at medical and family history, cognitive tests, physical and neurological exams, we have two groups of or families of biomarkers, and these being fluid and imaging biomarkers. So fluid, plasma biomarkers, CSF biomarkers that's, extracted using a lumbar puncture, and then imaging biomarkers such as MRI that's used to look at the structure of the brain, FDG PET looking at metabolic, changes in the brain, and then you have the imaging biomarkers that actually detect the hallmark pathologies in AD, so amyloid PET and tau PET. And the value of biomarkers in clinical trials and later in the clinic is that they provide diagnostic accuracy, ability for target engagement, confirmation of this target engagement, and biological measure of disease progression and a response to treatment. So when it comes to comparing PET imaging and fluid biomarkers, it's important to remember that both approaches, provide valuable information regarding disease staging and severity. PET imaging, may not be accessible to all and can be costly without national medical coverage. And CSF collection by lumbar puncture can be invasive and it has risks associated with it. So some people, think that blood-based biomarkers are the future in the field. And to a certain extent, that may be true, especially when it comes to the initial screening of populations. And because you can run multiple analyses on the same sample, but there are limitations with fluid biomarkers, including plasma and CSF. And these include, the fact that these are indirect measures of brain pathology, and they're sort of snapshots in time of what's happening in the brain, and they can be affected by other peripheral, processes in the body. And differences in collection, handling, storage can impact, the sort of measurements. And these have implications for longitudinal studies and monitoring of response to therapy. PET imaging, on the other hand, provides direct information about what's happening in the brain. And let's say with amyloid PET, it provides direct measurement of amyloid beta load in the brain, with fluorine-18 tracers providing a 96 to 98% sensitivity and an 89 to 100% specificity when it comes to this. And amyloid PET also provides valuable information about the topographical distribution of pathology, so across brain region. So where is the pathology? And this is very important when it comes to differential diagnosis. Which amyloid beta PET tracers can be used in the clinic currently? There are 3 FDA-approved radiopharmaceuticals, and I'm assuming that's the case here in Canada as well. These include fluorobetapir or Amyvid by Eli Lilly, flutometamol or Vizamyl by GE Healthcare, and fluorobetaben or Neuraceq by Life Molecular Imaging. They provide high specificity for the detection of amyloid plaques, and they have a longer half-life compared to the first generation tracers that were out there, such as PIB, that was labeled with carbon-11 and that restricted its use. So they enable the quantification of amyloid plaque burden in the brain, and they can be used for assessment of anti-amyloid treatment response. So here are some key features about Neuraceq. It can, as I mentioned, detect A-beta plaques with high sensitivity and specificity, and this was confirmed by histopathology in the clinical trials that were run. It has a high efficacy and safety rate, and that's been demonstrated in different clinical programs. It has a reliable manufacturing process and global coverage, and this includes the approval by Health Canada in 2017 and the manufacturing of Neuraceq by Isologic or Isologic Innovative Radiopharmaceuticals, who are the exclusive marketing authorization holder in Canada. So they're responsible for manufacturing, distribution of the product, and handling any regulatory or compliance-related matters. We also offer a robust reader training program, and that can be found at neuraceqreadertraining.com/learn. I highly recommend that anybody reading amyloid scans or interested in NeuroPET goes through this training. It's not long, but it sort of provides the information necessary to be able to read Neuraceq scans. And there's also good comparability between visual and quantitative analyses using Neuraceq. So here are some of the indications for use of Neuraceq and its usage. Neuraceq is indicated for PET imaging of the brain to estimate amyloid neuritic plaque density in adults with cognitive impairment who are being evaluated for an AD diagnosis or other causes of cognitive impairment. A negative Neuraceq scan indicates no or minimal amyloid neuritic plaque in the brain, as that's inconsistent with the neuropathological diagnosis of AD. A positive Neuraceq scan indicates moderate to frequent amyloid neuritic plaques. And I just want to mention that Neuraceq should never be used by itself to diagnose a patient, it should always be used as an adjunct to other diagnostic evaluations, taking into account, the level of cognitive impairment using neuropsychiatric tests and other clinical measures. It's currently being used in the clinic in large-scale consortium trials such as IDEAS, New Ideas, AMIPAD, and it's increasingly being incorporated into phase 2 and 3 AD drug development studies. How do we use Neuraceq, and what does the dosing, administration, and image acquisition instructions look like? So the recommended dose for Neuraceq is 300 megabecquerels, 8.1 millicuries, and in a total volume of 10 ml. This is injected as a single intravenous administration. There are no serious adverse reactions related to Neuraceq that we're aware of, and apart from injection site reactions such as redness, pain, and irritation, and these tend to be mild to moderate in severity and with a short duration. PET images using Neuraceq scans are acquired over 15 to 20 minutes within an imaging window of 45 to 130 minutes after the injection. And the way that we should display the images acquired by Neuraceq and interpret them is that they should only be interpreted by readers who have undergone the training that I mentioned. And the objective is to estimate amyloid neuritic plaque density in the brain gray matter and not to make a clinical diagnosis. And image interpretation should always be done independently of a patient's clinical features. The way the images should be displayed is in the transaxial orientation using grayscale or inverse grayscale. The other planes can be used for additional orientation purposes, but the way the images need to be interpreted is in the transaxial orientation. CT and MRI can also be used as an anatomical referencing tool. So how are the scans interpreted? Again, in the transaxial orientation, grayscale or inverse grayscale, and they're always read in a binary manner. So the scans are either positive or negative. And we look at 4 different regions, so the frontal cortex, the posterior cingulate cortex, and the precuneus, lateral temporal cortex, and the parietal cortex. And you can see those hopefully shown with the yellow arrows and the dotted lines. And the way they are read is that if one target region is positive, then the entire scan is positive. And for thresholding purposes, we use the maximum intensity of the binding of the tracer in the white matter to look for binding in the gray matter. So as you can see on the right-hand image, you have a negative fluorobetaben or Neuraceq PET scan, and you can see that the white matter structures are outlined, and you can clearly see them with not much uptake in the gray matter, so in the outer areas. And on the right-hand side, you have a PET positive scan, where you have now this sort of merging of the white matter and the gray matter, and there is definitely uptake in the gray matter in this particular patient. So how can knowing amyloid PET status help in the diagnosis and diagnostic confidence and patient management in the clinic? I'm not going to go through the nitty-gritty details of the studies, but let's say here there was a systematic literature search done, and they found that 31% of diagnoses were revised after an amyloid PET scan. Diagnostic confidence improved in 62% of cases, and care management changed in 72% of the cases. So amyloid PET provides valuable information when it comes to the diagnostic and the treatment, the care management of patients. The IDEA studies that you may be aware of was done as a multi-site longitudinal study, and they collaborated with over, almost 950 dementia specialists at almost 600 US sites. They recruited and enrolled over 16,000 patients, and these, included Medicare beneficiaries age 65 and over with a diagnosis of MCI or dementia. And what they wanted to see is whether knowing amyloid brain status, so pre-PET and post-PET, had any changes on AD drug therapy, the use of other drug therapies, and also counseling about safety and future planning. And then the secondary outcome measure was to look at changes in diagnosis. So you can see here that the overall change in both MCI and dementia patients was very significant, 60 to 63%. The use of AD drugs, was impacted in 40, almost, around 44 to 45% of patients. The use of non-AD drugs was changed in 23 to 25% of cases, and counseling was also impacted. And the use of, amyloid PET resulted in changes in diagnosis, reducing the chances of misdiagnosis. So almost 3,000 patients had a change of diagnosis from AD to non-AD, and from non-AD to AD in about 1,200 patients. So overall, a change of diagnosis in 36% of patients. And here's we're looking at diagnostic confidence in this slide. And on the left-hand side, these are the pre-PET likelihood of diagnosis. And in that middle section, you have this uncertain sort of range between 4 and 7, where 72% of the diagnosis fell into this, rated by the physicians. And post-PET, that likelihood, that uncertain region was sort of skewed either toward very likely and not likely. And then here's the proportion of AD diagnosis that increased with positive A-beta PET and decreased with negative A-beta PET. So pre-PET, you had 80% of cases that had an AD diagnosis. After PET, you had 95% of cases, but particularly with the PET negative scans. So 70% pre-PET were given an AD diagnosis, but these were amyloid PET negative, and then this reduced to 10% of cases being given an AD diagnosis. And the use of AD medications increased in both groups of, MCI and dementia cases with positive amyloid PET. And here's one of my summary slides. I hope, I've been able to successfully showcase. Oh, sorry. Oh, no. Thank you for telling me. Oh, my God. Okay. Thank you for telling me. So just quickly going back. Oh, no. There we are. You saw this one, right? You saw this one. And then here. Okay, that was the last one. So here are the changes in, patient care management, the overall change in MCI and dementia cases, being changed by 60 to 63%, and the use of AD drugs being changed in about 44 or 45% of cases. The use of non-AD drugs was changed at about 25% of cases, and then counseling as well. And then here are the changes in diagnosis. So from AD to non-AD, around almost 3,000 patients had a change of diagnosis from AD to non-AD, and non-AD to AD in about 1,200 patients. And here's the diagnostic confidence slide. So you can see that within the ranges between 4 and 7, 72% of diagnoses fell into this uncertain diagnostic confidence range. And after a PET scan, this was reduced to 16% only, with the number of very likely and unlikely cases being increased. And here's the slide on the association of A-beta PET with the proportion of AD diagnosis. So pre-PET scans, the PET positive scans, that increased by about 15%. And the people that had a negative PET scan, the AD diagnosis significantly reduced in this population. And the use of AD medications increased after positive amyloid PET. So both in the MCI and dementia group, it doubled in the MCI group, and there was like just under a 30% increase in the dementia group. So this is the summary slide. I hope that I've been, successful in showcasing that in addition to traditional neuropsychiatric clinical assessments, the incorporation of biomarkers in the diagnostic workup adds a huge amount of value and is becoming a necessity for a timely and accurate diagnosis, given that there are therapeutics coming out that are targeting the disease pathologies themselves at earlier stages of dementia. And, I think patients should and deserve to be identified early enough for effective care management and treatment before, more severe clinical symptoms occur. So here is an overview of the key takeaways. So AD is a common neurodegenerative disease, caused by the buildup of amyloid plaques and tau tangles in the brain, leading to cognitive dysfunction, dementia, and death. It poses a huge burden on patients, families, and healthcare and the healthcare system. For more than 100 years, we've known about the hallmark pathologies, but the diagnosis was mostly based on symptomatology and clinical assessment, and confirmation or a definitive AD diagnosis was only given post-mortem. It's now understood that AD is a spectrum that begins with a long asymptomatic period, up to 20 years, sometimes 30 years before the onset of clinical symptoms. And this sort of spectrum can be characterized by the emergence of biomarkers, with amyloid accumulation being the earliest detectable biomarker of the disease. And there are currently, I think biomarker detection can be used in living patients to enhance precision and accuracy, guiding practice decisions related to patient management, including when to add, when to withdraw, or consider treatments, or to plan for the future. And amyloid PET has been proven to impact clinical diagnosis, patient management, and improve clinician confidence in the diagnosis that they give the patients, and identification of AD and having an accurate diagnosis sort of sets the stage for intervention at these early stages and giving the patients the best chance of slowing or stopping disease progression and preserving brain function. And thank you for listening and participating.
Thank you so much for the nice comprehensive evaluation. We have a couple of minutes for questions. Okay, I have a few questions. Some physicians thought that FDG PET may be enough for a diagnosis. So what's your thought about that?
So FDG has, long been used to look at changes in metabolism in various neurodegenerative disorders. It's a valuable tool, but given that amyloid accumulates in the brain decades before you can see changes in synaptic dysfunction and what FDG measures, I think that it cannot be an effective tool to use in the early stages where patients are being, are candidates for therapy and these disease-modifying therapies that are coming out.
The other thing, that what role tau PET can play in the diagnostic workup?
Thank you for the question. I think tau PET is another, important piece of the puzzle. It is one of the two hallmark pathologies in AD, and knowing how tau accumulates, where it accumulates, how it progresses is very important. So given that tau is downstream of amyloid accumulation, I think it plays a role so using tau PET, it plays a role in understanding about the disease progression more than it's given a, giving patients a particular diagnosis of AD, especially given that tau is also present in non-AD tauopathies, such as, let's say, progressive supranuclear palsy, corticobasal degeneration, and studies have shown that tau also accumulates in traumatic brain injury and chronic traumatic encephalopathy. So I think tau, as well as being able to look at disease progression, response to therapy, later on, because it's a better correlate of cognitive decline, it also has value in differential diagnosis of various disorders, including AD and non-AD tauopathies.
Thank you so much, Dr. Mirzaei. Really appreciate the time. And
thank you so much for the platform.
Thank you.